So hello everyone, thank you for joining us again this evening, or if it's for the first time, welcome to the Kawakeb series. Now, Dr. Rawi won't be able to join us unfortunately today, so I will be making the introduction on her behalf and moderating later on. So we apologize again for the technical difficulties and delay, but without further ado, let me introduce Mr. Ziad Al-Ibriq. He is currently the nurse manager at the ICU at UBMC and is a specialized nurse in critical care in the critical care unit and in nursing for the elderly. Is a life coach and an accredited NLP trainer. He is an owner and CEO of Kane Group. It is a community service organization that provides online and in-person elderly and caregiver coaching, postgraduate geriatric diploma and advising, and is a consultant for a long-term care facility. He's also an elderly and caregiver coach at Help Those. He provides online coaching sessions for the elderly and caregivers about elderly wellness, advanced care planning, and caregiver lifestyle adjustment and management. He is a project manager for the nursing department and the strategic planner at Dar Salam Hospital long-term care facility. He was nominated previously by colleagues and received the Daisy Award in December 2016. He has worked as a registered nurse for the ICU at UBMC for the past few years and has a master's degree in gerontology from the Lebanese University. So without further ado, Mr. Ziad, if you would like to start.
Okay, thank you very much. Thank you for the presentation. I am logged in from another from the laptop now. Is there any echo?
No, it sounds fine so far.
So Diana, so you will share the presentation and I will speak about it.
Okay, I think it's Tala is sharing the presentation. Tala, you can, if you can tell her every time she wants her to change the slide, that would be great.
Okay, so first of all, good evening. Sorry for this inconvenience. I have technical problem here. And really, I want to thank Dr. Alawi for giving me this opportunity to share this presentation with you, which is Geriatrics failing to care is failing to cure. And first of all, the slide after this about me, thank you for deepest presentation, Diana. And the slide say, can science make us immortal? What do you think? What do you think? Mariam said, no, it cannot. We watch many films and the series and how the heroes, they want to be immortal. They do some magics, etc. in order to be immortal. Everyone like to live for بالمية and forever. So do you think can we be immortal? Tala, just if you may move to another slide.
Sorry to interrupt. Maybe it may be a delay in the. If you can stop sharing and reshare again, sometimes that helps.
You can't see it?
No, it's not changing on our end.
Okay.
Would you like to see if I can share now since I am logged in from the PC?
Yes, sure, if you want.
I will try to share from my side and we'll see what we'll see. Can you see now my presentation?
Yes, we can.
I move to the slide outline. Is it okay? Can you see it?
Yes.
Okay, so can you hear me very well also?
Yes, yes.
Okay, so
Good.
we'll move now. So the outline of our presentation now, it will be some epidemiology about geriatrics. We'll do two case scenario. We will see what is the best model of care for elderly, some legal aspect for geriatric, and what are the measures that help in ethical decisions. Okay. So this presentation, it will be around 20 to 30 minutes, and then we'll give you time to have any, if you have any questions, and to discuss some points shared in this presentation. Okay, so are you ready to start? Can science make us immortal? What do you think? Some of you said in the chat that it cannot, but as we all know that all of us would like to be immortal. But the aging is preventable or it's not preventable. If you can have some interaction, you can chat or you can unmute yourself, feel free. What do you think? Is aging preventable?
Of course
Not,
not.
but it
All
can
of us will reach an age, an age group, and older, elderly.
We'll all be aged, we'll reach it. We'll be elderly. Okay, so we'll see. Aging can be preventable, but it's inevitable. So we cannot evit and to be aged, but we can prevent the aging. How? It's about 80 to 85% is within our control. How do you think we can prevent? We will be aged, we will reach the age of 80, 90, 70. This is normal. But does aging mean I am frail, I cannot move, I cannot do the basic activity of daily living? So 80 to 85% are within our control. We'll see how. The global aging by World Population Prospect in 2019 said that currently around 7.7 billion elderly worldwide. But by 211, we'll have around 10.9 billion elderly worldwide. This means that the number of aging population will increase over all the world, not only in our country, but over all the world. And in 2018, for the first time in history, the person aged more than 65, they outnumber the children under age of 5. And in 2050, the person aged more than 65, they will surpass the adolescent age 15 to 24. The current projected percentage in the Middle East and North Africa of old population showed that in 2010, and now in around 2020, 2030, and 2050, the percentage of population age 65 and above, they will increase in the Arabic country also. And Lebanon is one of the top number 5 country who they have the highest population in elderly. Also, the life expectancy at birth, number 1 in the Arabic country is Lebanon. The average is 78.86 year. And here we show that the pyramid of the population, this was the normal shape. Usually it's like the shape of a bell. The base is the white one, and the elderly, they are the lower population. And if you see here, the number of population age, it will increase, and we'll have around 2020 in our current year, almost like the same number of population from young to 40, and by time this pyramid will increase in the population. So the health transition, we have decrease in the frailty rate. and increase in the mortality rate by increase of the science, by increase of the number of marriage are also decreased, mainly in the current situation after COVID and the economic situation in Lebanon. We all notice that the fertility rate and is decreased. And the mortality rate for all the population decrease. This will increase also the number of elderly in the country. And this increase also the lifespan of the population. It also has an impact in the economic factor. The support ratio is the number of elderly not functioning, they are not productive or working, to the current citizen in working age between 20 to 64 years. So in 1970, we have one elderly for every around 14 citizens working. These citizens are productive and they have an income to the country. And currently around 2020, we have one elderly for each 3.6 citizens productive. And this number also will decrease by day. We reach 2030, we have one citizen elderly for only 2 citizens, they are still working. This is highly impact in the economic factor for the whole population worldwide. The geriatrician over the population. In Lebanon, we have only تقريبا one geriatrician for every 20,000 person for age 65 years and over. In the Arabic country, we have one geriatrician for every 100,000 person age 65 and over. And in the US, we have one geriatrician for every 5 to 7,000 person age above 65 and above. So this means that the physicians specialized for elderly population, they are not enough to serve all the age population, which is another burden for these elderly. The geriatric and gerontology program in the Arabic countries, which teach gerontology and geriatric in the university as a curriculum in the medical school or geriatric courses, also they are not present in all the Arabic country. Very specific countries, they teach a curriculum of geriatric in the medical school, and mainly the focus is in the Bahrain and Egypt. And Lebanon is one of the also countries that they teach geriatric in the curriculum of medical school. This means also that there is no enough qualified professional skills and training for old people. And these old people are treated most of the time by a general medicine or any other specialty. And the other challenges also. The polypharmacy. The study showed that around every elderly is with the chronic disease and has around 7 to 8 medicines per day, chronic medication. And this is a burden in the economic factor and the bills for this medication. And the other challenge is the frequent hospitalization to hospital and intensive care unit, visit for the physicians. And the other challenge also is the not enough staff to serve the elderly in the long-term care facility. And also, as we mentioned earlier, and there is no enough trained healthcare professional to serve this population, the elderly population. So, with all these data and all these number statistics, the health service, the treatment of old people may be perceived to be less worthy than the treatment of younger persons. This leads to discrimination of old people in the provision of service, and the treatment approach is focusing by managing the disease since it's not treated by a specialized geriatrician for the disease. So what next? If we continue in failing to care, how we are going to face these challenges? We'll see a case scenario and we'll discuss what is the possibility. So we have Mr. R is a 75 years old male who lived with diabetes for a long time. He administered insulin and full diabetic diet, recently had urologic problem, and he received frequent antibiotic, and he do also at home self-catheterization. During your assessment, this patient came to the clinic and during your assessment as a physician, you notice that he is not adhering to his diabetic diet and alters insulin dosage based on how he feels each day. So Mr. R has the knowledge about diabetes, etc., but he is dependent on his wife to prepare meals, but now she is deceased. What do you think? What do you prescribe for Mr. R? What is the first thing that you think about it to prescribe for this Mr. R who is not controlling his diabetes and he might have many consequences for it? You can write in the chat or you can unmute yourself and share your feedback. What do you think? What is your first prescription or suggestion for Mr. R?
We ask for a who is his caregiver.
We are asking, no, we are not asking about who is the caregiver. You said, and you may ask who is his caregiver. Okay.
Yes.
So before doing any recommendation, you ask about who is taking care of him.
Yes.
We may send him to a nursing home, maybe. What do you think, Alf? Assess his support system, sibling, neighbors. Okay, excellent. So till now, you answered that before doing any medical management or adjustment of the medication or etc., we should look what is the main concerns why he is not adhering by his prescription, how his administration of the correct medication. So we ask who is supporting for him. So what do you think? Second question, what is the best model of care for Mr. R? And which model we have to focus with Mr. R? Silva said to stay within a family context. Okay, since the main cause is the disease of his wife, so the first thing he needs is to have a family that care of him. Okay, excellent. So I like your answer. So we should think about, and not only directly you are not adhering by medication to shift to another medication, give him a prescription. Okay, yalla, go and do. It's your challenge now to abide by this. So we have the focus about a holistic care model. This model, what elderly needs, we have the target is not just treating the disease by itself, rather than promoting health and healing approach through balance between mind, body, and spirit. If you notice that Mr. R, he was doing well, and his dextrose or his diabetes was controlled, but the trigger for him was the death of his wife. So instead of focusing to the disease just by itself, we should focus on all the dimensions of life of this patient by focusing not on his body as disease or treat the organ by itself, but focusing on his mind, why he is not doing this, to go beyond it, not to focus directly to the disease by itself, and what are the spiritual or psychological factors that might impact his compliance by this disease. This is the best model of care for all the patients, but specifically and mainly for the elderly population. So this holistic care model, so elder people, all of them have a chronic disease. We rarely see an elderly without a chronic disease or he is previously healthy. In addition, they are frail due to aging by the apoptosis of the cells, by sarcopenia, osteoporosis, by the dementia, they also are dependent for someone else to do his basic the activity of daily living. So the healing process, rather than their curative effort, will be more beneficial. So our goal is to focus on maintaining the intrinsic capacity and functional ability, and we have to move from disease-focused approach towards care that aims to enhance all their intrinsic capacity over their life course. And the main intervention that you may do is to prevent and not to treat the symptoms or disease when it happens, but the preventive measures in the elderly population are our main focus and concern. This is the iceberg model. The iceberg model of health. As you see, what do you see here in the top of this iceberg? So if you are looking to someone, what you see in the state of health is just a small percentage of the current state of health. And when you are looking for someone, you are assessing someone in the clinic, in the long-term care facility, at home, wherever you see a person or an elderly, the current state of health is not just what you see. You have to look beyond it. You have to look what are the base of this current state of health by focusing on the spiritual part, the values and beliefs, what does things mean for him, the psychological part, what does motivate him in order to be active in this activity, what is his lifestyle and the behavior. So once you see or assess a patient, don't just look at his currently what you see state of health, but you have to focus on the base of his behavioral lifestyle and values. And the illness-wellness continuum. The neutral point is someone with no disease, without illness, or without wellness. But the more you have disease, you will go to disability and premature death. And that's what we see for the elderly, mainly in the frail, the dementia. They will be functional, they lose functionality, they will be totally dependent in IADL, and then will be dependent on ADL, the activity of daily living. Then we'll see, will be totally dependent and is the premature death. But the target here is to focus on the awareness. Even if you have disease or symptom for a disease, but the more you have awareness, education, and knowledge about how to manage, how to deal, how to prevent, you will reach the highest level of wellness. So if you prevent the disease, if you prevent the exaggeration of this disease, you will reach the high wellness of the high level of wellness, and mainly by focusing in the all dimensions of life. Well, this is the health. The health is just around 1/10 from all your humanity. This is me as a human. I'm not just health, but all dimensions of life, they might affect the health as a body. But while you are taking for an elderly, you have to focus not only to treat the disease, but also and managing the disease, but to look all the factors that may affect him, that's why he is not taking care of his health. And mainly the family factor, if there is someone who is taking care of him, the social factor, if there is any next of kin, and the financial factor. And mainly if you are talking about in Lebanon, the financial factor now is one of the biggest challenge for the health in general. When you are searching for the medication to treat, it will be a high challenge in Lebanon to treat and to manage disease. And this may be it could be a shift in the way of thinking about how we should manage the patient and mainly the elderly population. So if we fail to care for these elderly, we will fail to cure them not only by focusing on the disease by itself, but on all the dimensions of life. So some challenges and legal aspects, they are frequent in the elderly population, and most of them, they are the consent and the patient competency. Is this patient competent to take this decision or no? He's demented. He's not has the functionality to speak or cognitive functionality. The end of life issues are also the main dilemma. Shall we put this patient not for resuscitation or not for intubation? He's just comfort care or palliative care. We have a many dilemma in this point. Each point of this legal aspect will cause a big challenge. The confidentiality, the restraint and abuse. You are sometimes abusing an elderly without know that you are abusing him. By neglecting to care of him is also an abuse. Not the abuse is just by physical abuse or pulling or pushing him. Also, the emotional abuse is also one of the main legal aspects. The advance directive, most of the studies showed in the long-term care facility, there is no patient, they didn't sign an advance directive. So we don't know what is the will for this elderly, what he would like to do in his end of life. There is no advance directive. So these are the legal aspects. If you want to talk about each one of these, it will take around one presentation. So the case scenario, you remember Mr. R. So he moved now, he decided because he's not able to control his diabetes and by himself. So he decided to move to live with his son. 1 week ago, he was diagnosed with prostate cancer also. And this prostate cancer is metastatic to brain and bone. Mr. R developed suddenly a decreased level of consciousness when he was at home. And he was admitted to the intensive care unit because of decrease of consciousness. The oncologist claimed that he has a poor prognosis and non-curable disease. This cancer is also metastatic to the brain and it's non-curable now. So Mr. R advanced directive before reaching this situation, he was discussing his advanced directive with his son, and the decision was to let him die in peace. But since he is not competent now, his son now decided to do all the treatment and procedure needed in order to not to feel guilty. You face this situation almost in ICU, in intensive care unit, almost every day. Since the patient, they are not competent, they are sedated, they are intubated, they are weak, they have this loss of consciousness. The next of kin, or the surrogate member, they are the close family member. In this situation, we met with them to discuss what would be our next step in the management. So does Mr. R's son have the right to decide full measures, even if the patient was the will was to let him die in peace and to have a comfort care without intubation, without sedation. But his son decided and to do all the measures in order not to feel guilty. And if we have a chance now for 1 hour and to do all the measures. What do you think from your point of view? Is he right to do this or no? Is the Silva said, is the will legally validated? I don't know. It would be. We have to ask about this. But let's suppose and know it is validated or it's not validated. Let's take the both case. And you as a healthcare professional, in this case, do you have the right to oppose the son decision? Okay, so here in Lebanon, what happened, since the patient there is no official document about his will, first of all, in this case, we consult the risk management team in such legal aspect and decision. If the physician said that there is no a futile treatment, this disease is futile, we cannot treat him, or etc. If we have still dilemma, أكيد we consult the ethical committee and the risk management to take such decision. But since there is no official document about his will or advance directive, and here it's rarely done in our country. So since his son, he is the first next of kin who has take decision. So usually we go by the will of the son and the decision taken by him. But the question and the main question is, what do you suggest to prevent such dilemma? Here's a key point. So to prevent such dilemma, what is the preventive measures in order not to reach this level and to have this dilemma? What do you think as an ethical perspective we may do to prevent such dilemma? Jihad said that he can do that. Yes, he can do this. Start with the previous conversation of end-of-life care early on. Yes, excellent, Eva. Thank you. The main gap is to early start the advanced care planning and to discuss the end-of-life care, not only to wait the patient to reach the level of decreased consciousness in ICU, he's critical, he needs intubation, yalla, what you want to decide? No, whenever you face a patient, he is in a chronic non-curable disease, this is the first time, is the earliest possible to do the advanced care planning, to discuss the advanced directive, and to consult the palliative team, to consult the specialist in these cases. This is the best time to do this. We need to consider each country's law and policy excellent. We have to consider some legal aspect is different from country to another. The religious also perspective for each patient by itself also may change all your plan or management. This is also one of the challenges we have to take it in consideration when we have a diversity of the religion in the country. We need to amend our policies. Okay, so how to prevent? We finish by the measures also to help take these ethical decisions is let the patient express his desire. Anna, my point and my focus is what the patient needs, what the patient will, not your will as a son. If the patient is awake and he's competent, what he will decide to do, what his will. That's why the early advanced care planning decision before this patient reach the metastasis and the decreased consciousness is the best time to do this advanced care plan, the early possible. Also to identify and involve the caregiver in the plan of care since the beginning of the disease, not when we are in acute critical situation. They will be aware about the disease, they will be aware about the prognosis for this disease in this case, so they will be more, they don't go just by emotions and let him do everything to prolong his life, but to do what add quality to his life and not to add days to his life. Know yourself, let the patient know himself what his disease, what the symptoms might face, what is the track that he will challenge. Develop your own knowledge by education, send a brochure, education for the patient about the disease, about the prognosis, increase the awareness about the symptoms, how he will face these issues is also may decrease this ethical decision. To have an ethical committee in the institution, any institution you have, is to choose an ethical committee, and whenever you face such issue, to consult them to help in this decision and discuss the the whole situation with the family, with the patient, and not only when you reach the end of life, but before, in each phase of the disease, to discuss the plan and to meet from time to time, not only in the acute and critical situation. These measures, if they are applied, it might help in decrease ethical dilemma, such happened with Mr. R. And we conclude all these measures by early discussion about the advanced care planning, and during the advanced care planning to involve the patient in the plan of care and to discuss his values and beliefs and let the decision be based on his values and beliefs, not focusing only into treating the disease. Maybe these diseases, they are not curable, they are chronic, we cannot cure them. We have to control the symptoms, but our focus has to be to have an equilibrium between all the dimensions of life in order to have a best quality of life, to live with dignity and not with pain and any other challenges. And thank you for your time. If you have any questions, feel free to share it with me if you want to discuss anything.
Thank you very much, Mr. Ziad, for this very enlightening presentation. I guess I would like to pose a question before if anyone else would like to do so as well.
Yes.
When you mentioned you were talking about the importance of talking to the patient beforehand, before getting to the critical stage, and involving the elderly patient in the plan of care and the progression of the disease and what they will decide to do at the end of life.
Yes.
However, when it comes to, if we want to think about our culture and the context that we live in, we know that in some cases we have families that are a bit overprotective, and perhaps they hide the disease from the elderly patient. They tell the physician, don't tell them about their real prognosis or about the disease. And what is I mean, from your experience, how do you think this can be addressed? Just to fully educate the patient and involve them properly.
Yeah, thank you for this question, Diana. We face this issue in our daily basis. And it's not really scenario what you mentioned. We face it on a daily basis, mainly in our country here, in Lebanon, in the Arabic country. The family is still almost very close to others, not in the other countries. So in this case, sometimes we have the family, they trust the physician, the physicians, and they said, I want to discuss with the physician to know what is the plan, the disease, and the main plan to prevent such dilemma is to early discussion about the advanced care planning, and let them put themselves in the patient, and know if this patient, he is alive and he is going to decide what he is going or she is going to decide. My master thesis in elderly was about health coaching, the impact of health coaching approach in advanced care planning for the elderly in long-term care facility. So this might answer your question. And when we applied in the advanced care planning, all the person or the elderly said, and the surrogate mentioned that they had never discussed advanced care planning, and no one discussed about the advanced directive about the patient will. So the early discussion, and we also applied the health coaching approach, the focusing about the values and beliefs for the elderly. And this showed that when we discussed about the values and the beliefs, the way of thinking about the disease by itself and the plan of care changed. And the result showed that the decision taken by end of life, the medical decision and end of life decision taken compared by the controlled group choose, it's a change. We go more to the comfort care, the palliative care, instead of doing full measures, intubation, hospitalization, dialysis, and etc. So from my experience is to have a proper communication. Even healthcare professionals, they are not well trained how to set this type of communication. It needs a training, and it's not easy to discuss such cases and advanced care planning, and to focus during the communication about what the elderly and the patient know about the disease first, before starting telling them, and no, this disease is 1, 2, 3. And during this conversation, we mention and we focus about the values and the beliefs of this patient, and then we shift by the end to the plan of care. So before giving them, yeah, this is the data, this is the symptoms, the prognosis, this is the plan of care. What do you think? So changing, like, rephrasing, changing the way of thinking before going to the end point, which is the taking the decision about the disease. This is based on my experience, and it really helped during my conversation with the patient. Hope this answered your question, then.
Yes, thank you very much. Actually, seeing some of the comments in the chat, the last point is actually also relevant here, that we need specialized geriatric nurses and doctors. So what you described with regards to the communication process, who does this? I mean, does this fall only on the physician, or are there other members of the healthcare team that can be involved and in this process and can handle this communication?
Currently in Lebanon, usually the physicians who take the lead in such decision or discussion of the advanced care planning. But if you are a specialized nurse in geriatric, you can handle this discussion. And what we did in our thesis project, we created a new model of care, an advanced care planning, a new advanced care planning, and the discussion was done by us, as nurses. So we can take the lead if you are really specialized and trained how to handle such discussion, because a very simple change in the way of communication, it will change all the plan. That's why I usually apply the health coaching approach as life coaching and neuro-linguistic programming in the way of communication, because this coaching approach, the main focus is the coaching. And by coaching, you focus about the mentality and how you look and how you think about things in life in general. And that's what we implement in this discussion, and know how to plan for the end of life from the beginning of the disease, not when we have an acute critical situation. But yes, we can as nurses do this if we are specialized and trained. But unfortunately, in Lebanon, we still don't have this specialty. Even the geriatrician, we don't have enough geriatrician to do such advanced care planning. We focus mainly on the main physicians. If the patient has many comorbidities, so he tells you that my physician is X cardiologist. So this discussion was done by the cardiologist. We don't have a specialized team, and this should be done by a team, not also by a physician or person. We should have a social worker, psychologist, nurses, physician. A multidisciplinary team has to be done in order to set this discussion.
Yes, exactly. I think some of the comments in the chat also are reiterating that. Let me just go through some of them. We have Ms. Silva was saying that that we need to involve religious leaders as well in the palliative care teams, and someone else said
that team from all dimensions. psychiatry, and a dietitian,
Exactly.
social worker, physiotherapy, a religious person, all the hierarchies be involved. That's why I mentioned here in the my life wheel of life. So we do like an exercise. We rate from 0 to 10 which point of the wheel of life is low. So we focus in our plan to the lowest rate before focusing on the other, because if we can manage this dimension, it will impact positively to the other dimensions, and indirectly also it will impact the health. Like Mr. R, if we focus in our plan of care about the family, someone who can take care of him, we will impact his control his diabetes and his health, instead of focusing to the medication adjustment for him. So yes, we should have a multidisciplinary from all dimensions to take care or to handle properly such cases.
We also have another comment from Ms. Naila Al-Hajj, that there's an important pillar that should have been mentioned. Perhaps it's a topic for another talk because it's an important one as well.
Caregiver,
With regards to the mental well-being of the caregiver themselves.
Yes, of course.
Definitely.
100%. I'm sure I'm with you 100%. That's why in Kane, which is the coaching, advising, and nursing for elderly, I do life coaching for the caregiver. And I want to focus about the caregiver because all the burden are for the caregiver. Also, we have a scale to measure the burden of the caregiver, because if they are well physically and mentally and financially, etc., if they have resources around in the community, they will take care of this elderly in the ideal situation. But if they are not mentally and physically and socially supported, how they are going to take care for this elderly? That's why indirectly, as I mentioned, we abuse this elderly by neglecting him, by pulling him, by emotional abuse. So we abuse this elderly because we are not well by ourselves in order to take care of him in the proper situation. That's why if we fail to care of him, not to treat, if we fail to care, we will fail to cure.
And unfortunately, of course, this is becoming even more and more difficult with the situation, the current situation in Lebanon.
Yes, the current situation in Lebanon, yes. Unfortunately, it's very, very bad situation. I mentioned, even we don't have the medication to treat. I'm not talking about taking care of, but even to treat the symptoms even.
We have an important question in the chat from Mr. Ahmed. What tool is validated to measure the caregiver's burden?
There is a scale. There is different scale for elderly. There is 100 of scales to measure the cognitive depression, functionality, frailty, and also we have a scale to measure the burden for the caregiver. There is a scale, burden for caregiver. I don't know if this is a question or if it's validated or no. Yes, there is a validation for such scale for the caregiver burden.
Sorry, if I may ask.
Yes, sure, Fadal.
Yes, sure.
Hello. Thank you, Mr. Ziad. I just want to ask about the wheel of life that you just mentioned. It is self-reported by the elderly himself, or do you put the points for him?
No.
For example, in the love or recreation or family components.
Yes. First, before you have to do a comprehensive geriatric assessment. Part of the comprehensive geriatric assessment is to measure the cognitive function. If the patient is totally if he has no cognitive impairment, so you can let the patient rate each dimension by himself. You told him, 0, it's very bad, and 10 is the ideal situation. And he evaluates himself, well, in the family, if I live alone, no one is taking care of me, he might rate it by 2 or by 0. So his health, he might be have many comorbidities, but he look at himself that I am well. So his health could be 10 even if I have disease. That's the difference between wellness and the health. So even if I have disease, I could be in a well situation. And so the patient rates himself. If the patient is not well cognitively, so the discussion, it has to be with the surrogate member and the next of kin.
Okay,
And
thank
the
you.
plan of care, it has to be focused on based on the rating. And Anna, if I mentioned that the family, all of them, they are rating 8, 9, 10, etc. And my focus is the social and family. So my plan of care in management and focusing, it has to be focused on someone to take care of him. I might think about home care. I might think about a private nurse. I might think about consult social worker. So it depends about the rating. It will direct your plan of care and decision based on this rating. It's like a tool to know where to focus, and we put like a mapping process, which is the area of focus, what are the action plan, and we do a re-evaluation after in weekly basis. This will impact in the health without focusing in the health to the health. So this is the health coaching approach in management the elderly, not in care of him, not to treating the disease. This is the main holistic approach of model of care for the elderly.
Yes, thank you.
Thank you.
So I think we will check just 1 or 2 more questions that are already in the chat, because we don't want to keep anyone over time. I think someone's asking about where can one pursue a master's degree in geriatrics in Lebanon, and are there any online recognized accreditations?
There is master degree, okay, other than Ain Hussein Hospital, which is in the Lebanese University. There is also in the AUB. There is a master in adult and geriatric. These 2 universities, you know, they give an academic master degree. I don't know if there is other university in Lebanon.
So we have all that evidence here, a couple of pages of just sort of points. Again,
Thank you. So are there any
Naila mentioned also any
final
online
comments?
recognized accreditation while living in Lebanon. You mean, I know there is online accreditation to take specialty for geriatrics? That's what